This is a human heart, perhaps the most vital organ of our body, the driving force of our life, the seat of all our emotions. On an average, our heart beats around 72 times per minute. That is over 4,300 beats per hour, over 100,000 times per day, almost 38 million times per year, over 2.2 billion beats over an average lifetime. This equates to around 400 million liters of blood pumped by an average heart in an average lifespan, enough to fill well over 1,000 swimming pools. And this is achieved with an amazing speed and force. Even at rest, our heart muscles work twice as hard as the leg muscles of a sprinter while sprinting. Our heart needs to be in the perfect shape. This unique piece of machine is under the continuous threat of the so-called cardiovascular events, some beyond our control. But thankfully, there are some risks which can be addressed, thereby addressing the risk of cardiovascular diseases. Cardiovascular diseases have been broadly classified under two heads, with heart attacks and strokes falling under atherosclerotic, and heart failure, arrhythmia, and heart valve problems forming the others. In newly diagnosed type 2 diabetics, reduction of HbA1c is associated with significant reduction of heart attacks. A good control of blood sugar, along with all other modifiable risk factors, is therefore important for diabetic patients, especially patients with existing heart conditions. While correction of hyperglycemia has been shown to reduce atherosclerotic events, there is no single approach to reduce blood sugar. And unfortunately, some of these approaches may actually increase the risk of some of the other types of cardiovascular events, especially heart failure and arrhythmia. It is therefore important to ensure that the anti-diabetic we are using to reduce micro and macrovascular complications of diabetics is also safe overall in diabetic patients with CVD or high risk of CVD. The challenge that clinicians usually face is that the benefit of glycemic control with an anti-diabetic may mask the small risk of increase in some type of cardiovascular events. One should therefore compare the individual approaches with other approaches which provide similar glucose lowering. In a large meta-analysis comparing the sulfonylureas and gliptins, the risk of cardiovascular events was 47% lower with the gliptins. In another meta-analysis of 67 studies which compared DPP-4 inhibitors with placebo, while the overall odds ratio was 1.37. The same was 0.34 with sitagliptin. In meta-analysis of sitagliptin studies alone, the overall hazard ratio with sitagliptin was 0.83 compared to patients not exposed to sitagliptin, and 0.00 compared to patients on SUs. It was still not known whether sitagliptin and other new anti-diabetics could increase the composite or any individual type of cardiovascular event. The answer was provided in the form of a very large cardiovascular safety outcome studies conducted with the newer anti-diabetics, where the effect of glycemic lowering nullified with the glycemic equipoise, a strategy similar to glucose lowering in a comparing arm. TICOS, the cardiovascular safety outcome study with sitagliptin, was conducted in over 14,000 patients over a period of 3 years. To nullify the effect of glycemic benefit of sitagliptin, not only a similar glucose lowering was targeted in the comparator arm, the average HbA1c at baseline in both the arms was 7.2%, very close to the usual target of 7% in such patients. Given the already existing wealth of evidence existing with sitagliptin, it was probably of no surprise that adding sitagliptin was not associated with the increase of the primary endpoint of composite of CV death, non-fatal heart attacks, non-fatal strokes, or hospitalization for unstable angina. It was also reassuring that there was no significant increase in any of the individual types of cardiovascular events. More importantly, the cardiovascular safety of sitagliptin was established in patients irrespective of sex or the age group. With the time-tested efficacy and safety across a broad range of patients, we now know for sure that sitagliptin does not increase the overall risk of cardiovascular events or any specific type of cardiovascular event. It doesn't increase the risk of an event of heart failure in patients with or without existing heart failure. It doesn't increase the risk of stroke. No, not even numerically. And it is just as safe in patients less than 65 years as it is in patients more than 65 years. Our heart is an amazing machine. When you treat diabetes with an anti-diabetic, choose confidently a therapy that is effective across the spectrum of diabetes, is indicated in a broad range of patients, doesn't increase the risk of hypoglycemia, doesn't increase the risk of composite of cardiovascular events, or any particular type of cardiovascular event like stroke or heart failure in patients with pre-existing heart disease, and most importantly, is backed by evidence to support the claims. Consider sitagliptin, backed by experience as well as valid evidence. Januvia gives you the confidence without the compromise.